been taken courtesy of Capital FM. Thank you, Capital FM, MD Bernard Momanyi, for bringing this interview because I'm almost there. I feel like I have one hand on the trophy. I feel like Arsenal now. Everyone knows we're going to win it. It's just a matter of time when we do.
It's only a matter of when.
Yeah, it's only a matter of when. So, we have a guest in studio, and we're about to delve into it. It's Captain in the Morning, of course, with Fellaris and myself, Chiko. Good morning, Rambo.
Well, good morning, Humble Larry.
Yeah, thank you very much, Mr. Humble himself. I'd be far from humble if my name was a mix of two former presidents, Daniel and Mwai.
Come on.
Think about that, Daniel Mwai and Mwai Kibaki.
Quite a combination.
So you combine those two names and you have a man who also happens to be, apart from those two names for two presidents, happens to be an advisor on health financing for the current president. So three presidents in one. Daniel Mwai, Mwai Kibaki, and President Ruto, my future father-in-law. And we have Daniel Mwai. Good morning and welcome to Capital in the Morning.
Good morning, and thank you for having me.
Yeah, no, the pleasure is absolutely ours. By the way, don't worry about the introduction. We'll deal with Charlene's situation later. I mean, 6'7", 67. You know what 67 means, right? Because you look at this face that you're not with it. You don't know this new lingo of you guys. You need to be young at heart.
We are trying.
Yeah, bana. Gen Z leader wenu hajawafunza 67. Oburu hajakuja.
Trying.
Okay.
Trying to align.
Daniel Mwai, President Advisor on Health Financing, right here on Capital in the Morning. Good morning. Glad to have you in the house. Just out of curiosity, because we were talking about health earlier this morning with Laban Wanambisi, and I just want to get your overall feel of the health situation in this country.
Thank you very much. I think two things I just want to highlight. One, and as you have put it well, I'm a health economist.
Yeah.
With a PhD in health economics. Needless to say, a lecturer of the University of Nairobi, specializing in health economics again, in both College of Health Sciences and the School of Economics. I think I've done this work on healthcare financing since 2006. That now is almost going to 20 years.
Wow.
And my key area has always been how do we craft the African architecture for healthcare financing to respond to the health needs of the African states. I have worked in 68 countries by now. So I have a fair view of the healthcare financing landscape within the whole of this area. Now, Kenya, as you may know, have tried to get to this UHC for quite some time.
Yeah.
And it started with, it has been coming from Mwai's time. The first time we made serious deliberations to actually move towards getting UHC was Kibaki's time, the Giro Bill, the famous.
Yeah.
And it was a very fantastic bill that was never implemented. It never saw the light of day. And of course, it died. It was not assented to. The fear then was that a strong social insurance probably could kill the private sector, which I don't think was right then. And of course, who will finance it was a big question. After the failure of the last regime also to be able to roll out UHC, they did the four counties pilot. It failed. There was learning there. Now we are in President Ruto's regime. It's trying to do the what have failed over that period of time with a lot of learning, because every failure gives you a chance to learn. What did I not do right? And that's why I like taking people to a report that was done after the failure of the last regime to actually actualize this, a report that was written called the NHIF We Want. It documents all the problems we have had, why we have failed, and how not to fail.
Okay.
Now, that is where the current healthcare system is starting from.
Okay, so let's just zone into this report, because I haven't read it and I'm just trying to pick your mind. So if I were to ask you the three main reasons according to that report, the three must deal with reasons if we are to succeed, what would that report have said?
So there are four reasons, actually, so to speak.
Okay.
The first reason that I want to highlight relates to the issue of commodity security. This is not sure. This is the universal health
Yeah,
coverage,
yes.
the health initiative, which is beyond SHA, so to speak. So this is where we are talking about commodity security. And the question that we posed to the people then was, why do you bypass the nearest health facility? Number one. Two, why is it that you don't go to the hospital? Two things. One, they highlight that when you go to the hospital, there's no medicine. So if the hospital near has no medicine, I cannot go there. Now the second is, if I go there, I may not get the right human resource. So I don't, doctors have been on strike for so many years. Nurses, the same. We have had a shortage of human resources within our facilities. So we don't have the services, we have buildings. So why would I go to a building? I need services. So that is reason number two. So the first one is commodity security, which talks about medicine. The second is lack of human resources. The third is lack of diagnostic capacity. Those are the three main issues that affect why people do not go to facilities. They take long. By the time you are going, the disease have already progressed. You are in a worse position. You spend now more money to try and remove a disease that ideally would have addressed when it was early, if you went on time. And that then formed why our Taifa Care initiative is founded of the four areas. One is commodity security.
Yeah.
Two is human resources for health. Three is actually digitization as an enabler. As an enabler. And the fourth is healthcare financing. But people take a lot of time to discuss the healthcare financing component. So much that it is buried in a way that we don't talk about the other three.
The other three, which are very vital. So, like you said, UHC, healthcare is like the country. All right, you zone in, you come to Nairobi. You zoom in further, then you come to certain streets in Nairobi, and you see the reality on the ground. So let's zoom in. The NHIF we want. How has SHA given Kenyans that? What is the NHIF Kenyans wanted, and how close is SHA to giving it to them?
I want to begin by saying we are on that journey to getting to the NHIF we want. And I want for us to address that issue, I need to highlight to you what was the issues addressed in that report. Number one was that the human resources that were managing NHIF, 60% were not fit for purpose. You are a geologist, you are in claims. All right? Just an example, a little example. You can go and look at how it was going. Now, when you look at that, then how does, when a doctor send a claim for treatment, how would a geologist, for instance, look at it? All right? You are in the department of benefits, you have no actuarial background. How do you determine how much people should pay? So one of the things was the human resources. The second was governance. Who should play part in the right governance of SHA? Who should be in the board? Who should they represent in the board? Now, when you look at that report, it actually suggested who and how should how should this board be constituted to make sure there is representation, there is accountability, and there is also desire that those who are in the board represent something. For instance, we have a representative of providers that was not there. We have representative of workers. We have representative of doctors. We have a representative of those who provide finances. Currently, in the current architecture, when you look at the board, that was addressing the governance and human resources issues. Because as a premier institution like that one, you cannot let it go that way. The other thing is that NHIF was always crafted for employed people. The non-employed people, nobody used to care about. And when you look at enrollment of the non-employed, it has never gone beyond 1 million. In the lifeline of NHIF, never. That means the fund was crafted for an architecture that Kenya moved from, because we are heavily in the informal sector rather than the formal sector.
What's the number comparison to SHA?
80 to in terms
of
so
million
let me
unemployed,
the country
1 million
is 20 to 80 employed to formal to informal.
Yes.
Now, SHA has more than 2 million households that are actually informal now.
Doubling the
It's
NHIF.
double 1 year later, just a year.
What's the contribution like?
All right. Now, the contribution structure, which I was also coming to, the other problem was the contribution structure. And I think you are taking me in the right direction. The contribution structure will surprise you. And it's good that we give this information for also Kenyans to understand. When at the NHIF, I first want to tell you there was no method of determining how much to contribute. The 500 that we have been talking about was determined in Mombasa in a meeting I was in by some members of political class, by just saying, let's move from 250 to 300. Another one said, let's move to 750. And then someone said, 500 is in the middle. That's how we got the 500. That's the reality.
Very professional.
So a lot of work has gone into trying to make policies surrounding 500 that was arbitrary in the first place, and benefits to be given were not known. So what happened in the SHA system is to actually get a method of actually determining how much money do we need, and how can we raise it, and how much should each person contribute. And I want to shock you to tell you that the poor NHIF was regressive. Regressive means you punish a poor person for being poor. The more you are poor, the more you pay a higher proportion. Now, and I want to give you a practical example. I'm a man in the village who has 5,000 a month. The NHIF contribution was 500. Okay? What is the proportion? 10%. 10%. Because you know, that's the reality, that's how it was working. Now, come to a person who is earning 100,000. The contribution was 1,700. That is 1.7. Now, go to some person earning 1 million. They were contributing 1,700. The contribution was 0.017. The poor, 10% of their income. The one with some resources, 0.017. Is there fairness? Now, that is one of the issues that the NHIF we want report highlighted. This should be addressed. Now, there was no publication of entitlement. What am I entitled to if I pay? That's another key question that people should actually see change. Now, the law says you must publish the benefit in a gazette notice where everybody can access them, so that by the time you pay for SHA, if you can read, you go to their website, you download, you go to the gazettes where they are placed in the government documents, you download, you can read your benefits and know what am I paying for, what am I entitled for. Now, that entitlement never used to be there. The last shocking thing was that NHIF was like the beginning and the end. It was determining how much to pay, how to pay, from who to pay, and if a provider have a dispute, they were the dispute resolution authority. Now, then you have nowhere to go, because if
Judge,
I told you,
jury,
I don't care.
executioner.
Yeah, so it was like pushing these providers and anybody with a complaint to nowhere. What has it created? Again, the NHIF we want said, let's have a separation of laws so that somebody else do the dispute resolution. And the last one, the administration cost of NHIF at some point was as high as 40%. You correct 100%, you use 40% to pay your salaries and admin and billboards and advertisement. And the lawyers you saw, they were being paid millions of shillings.
Yeah.
Because admin was free. It was not capped. What have this one done? They have said you cannot go beyond 5%. 95% of the money collected must pay for health benefits. I think that is a major change, so to speak. That's
Daniel
where we want to go.
Mwai, President's advisor on health financing, a man who's here to speak about SHA and health in the country, a man who is not only an expert in that, an economist in that area, but also a lecturer at the University of Nairobi. Well, when it's open, considering now they're on strike for reasons that actually you can wear both
Also
hats at
teaching
one
in
point, but
Strathmore
yeah,
is open.
so that's an interesting one. Hitting us with one shocking vibe after another. So now one of the things, the key things I've taken from this is the fact that you can pay and follow up in terms of your benefits and what your benefits are like, if as long as you can read, which was funny the way you threw that in there. But you can actually follow up, so you know, what am I paying for? Thing is, once you've paid, that money is not in your hands. It's turn for SHA to make some payments. How's that happened? We'll be back with Daniel Mwai to discuss that.
Some sounds never fade. Some memories just get better with time. For more than 10 incredible years, Sunday afternoons have belonged to the classics. Join the master of the turntables, DJ Adrian, as he spins pure gold, where you can hear the warmth of vinyl, feel the soul of yesteryear. 2 magical hours, where every crackle tells a story, where every beat brings back a memory. From the smooth sounds of the 70s, through the unstoppable groove of the 80s, to the unforgettable hits of the 90s. This isn't just a mix show. This is a time machine. Let DJ Adrian take you back, where the music was real, the feelings were pure, and every Sunday afternoon became legendary. Make Sundays old school. Sundays with DJ Adrian on Soul Groove. A decade of making memories, 3 to 5 p.m., only on Capital FM, where classics never die.
Hear that? James just found a new way to curate his best life thanks to the new Samsung Galaxy S25 FE. Explore new ways to create with the slimmest and lightest Galaxy S25 Fan Edition phone with an epic 50-megapixel ultra-wide lens and Galaxy editing for precision detail content. You get the kind of quality that will make you say, clock it. Down for new ways to play? Level up with a powerful processor, larger vapor chamber, and immersive display for seamless gaming. Out with the old, in with the new. Galaxy S25 FE, your true AI companion.
Capital Traffic and Travel.
Well, let us know what's going on around you. Traffic situation, incidents, accidents, 0701984 Well, the roads looking quite busy. If you are on Thika Road, Wagwan, because that traffic situation is one that, will have you sat there for a minute and 2 and 3 and 4. Count that all the way to 15 because that's the amount of delays you are going to be experiencing. Red Hill Link Road also getting affected, but hopefully you're enjoying the conversations that we have here on all matters health, and why it's very important for all of us to really understand how healthcare is structured outside of course what we read on the headlines. Heading into the CBD, well, traffic as you approach Haile Selassie, coming all the way from Nyayo Stadium roundabout, going down all the way to Kenyatta Avenue. And if you are on Waiyaki, that's as you're heading down towards Westlands roundabout, you can expect traffic on that road as well. Well, as you're in traffic, how about you map out how you're going to make your way into any of the outpatient centers for Aga Khan University Hospital, because up until tomorrow, this is an offer that's been running the entire month, and of course the offer is on discounted cancer screening. Now you can make your way to any of the outpatient facilities and get a mammogram for 3,100, pap smear for 1,350, PSA test for 2,650, breast ultrasound for 5,850, and an FIT test for colorectal cancer at 5,000 shillings. Now, once you do that, take charge of your health, and remember, mammograms are only available at the main hospital in Parklands and the current specialty center. And for more information, the number to call is 0730 011 888. That's 0730 011 888. But for any incidents, accidents, the number is 0701 984 984.
Capital Traffic and Travel.
Let's have one final test. Throw the switches.
Good morning.
Your morning dose of news, fun,
I have music in my life with Sam.
Allow me to demonstrate.
and all the hits with Chiko and Fellaris. Right here on 98.4 Capital FM.
Everybody move your body now do it. Here is something that's gonna make you move and groove. Hey DJ, keep playing that
So Kate Boogie had the show improve. Hey, now we're feeling the vibe, rolling with the flavor, feeling alright. Oh, yo, there's a party over here. Yo, oh no, the party's over there. Call up your friends, let them know fam's tagging along. Hey DJ, keep playing that song.
Everybody, move your body. Now do it. Here is something that's gonna make you move and groove. Hey DJ, keep playing that song all night, on and on and on. Everybody, move your body. Now do it. Here is something that's gonna make you move and groove. Hey DJ, keep playing that song all night, on and on and
The sounds of Johnny playing right here on Capital in the morning. Fellaris and Chiko. Hey, Mr. DJ. That was you yesterday, the midweek Wednesday mix down. And if you haven't experienced that, then you've been in the wrong radio station. Fam, missing Wednesdays is a disease. It should be illegal. It's like not paying for your shower and going to the hospital. And okay, that's a bit complicated. Story for another day. We'll delve into that conversation. All the same, you hang out with Fellaris and Chiko.
Getting
And
back to, yeah.
yeah, just a quick reminder, whether you've paid your SHA or not, you do need to get that cancer screening, whether you can afford it. If you can afford it and you've done it and you know someone who can't, please get them to do it, because by tomorrow, the end of the offer given to us this October, courtesy of Aga Khan University Hospital, where you get to get screened not just for breast cancer, considering it is the Breast Cancer Awareness Month. You get treatment, screening for all variety cases of cancer, including mammograms, which are only done, by the way, at the main hospital and the Karen Specialty Center. Mammograms going for just 3,100 shillings. Pap smear going for 1,350 shillings. PSA test for men. As we look at that prostate cancer possibilities, 2,650 shillings. There's breast ultrasound for 5,850, or a fit test for colorectal cancer, which is going to cost you just 5,000 shillings. Make sure you visit them, because that offer, those insane prices are only up until tomorrow. It's been an entire month. We're grateful to Aga Khan University Hospital, but that time has run out. You have today, you have tomorrow. If you're not going, get someone. If you can afford, do that good deed. Call 073 00 11 888 for details. Sasawa?
Well, absolutely. Well, jumping back to that conversation, of course, one of the things that I really want to get back to is the NHIF that we want. And 1 year of the country being under SHA, there's a lot of concerns which we will now get to and just get to look at them in terms of contributions, the three should I say pillars, or just we are talking so much about SHA but not looking at SHIF and the emergency care. We did have the emergency team here in studio, got to understand a few things there, but I want to go back to the NHIF that we want. Why didn't we look at a way, and this is the question that a lot of Kenyans have, is like, why did we have to create something completely new? Why not say, still under the structure of NHIF, restructure it to accommodate all of these things that SHA has brought in, instead of having a complete system overhaul?
That's a very good question. But I want Kenyans also to kind of have an understanding on what restructuring is all about. Mm-hmm. Restructuring include what was done. Actually, that is restructuring. Mm-hmm. Because when you look at NHIF earlier, it used to be National Hospital Insurance Fund. Mm-hmm. It became National Health Insurance Fund in 2019. Okay. Now, we only brought in the social component because it's a solidarity. That's why we are moving from contribute 10% if you are poor and contribute 0.017% if you are rich. It's a solidarity principle. Mm-hmm. 95% of the people globally do not require too much health expenditure. Mm-hmm. 5 do. So you come together, the 95 subsidize the 5% when they are in huge need of large catastrophic spending. Mm-hmm. So I want to first say restructuring is done like that. But as you restructure, you must address the critical issues that were raised that have made the other one to fail. If you read the 2019 report, and I want you to look at it, and I'll look for it, I send you.
Yeah.
It is said NHIF will collapse in 2022. It's not my report.
Oh.
It was written in 2019. And by 2022, NHIF was technically insolvent. They had 40 billion in liability that they would not pay. Exactly. So the report was technically done by a panel of experts selected who are not political. They gave the direction on how it was to be. So that one happened. So I want first to tell you, Kenyans should understand that what we have is a restructured and a rebranded system addressing the challenges of the old. And I have highlighted the challenges from the question that was asked earlier.
Yeah.
But want to highlight to you three things. One is that SHA is bigger. And it's bigger because universal health coverage must be for everybody.
Right.
That is why we have the primary health care fund. 70% of the health burden is primary in nature. You can check. So, and this one is funded by government, exchequer, through tax. So when Kenyans say we should have just loaded tax and pay for us, it is done.
Allow me
Because
to ask
that
you.
fund, you only register so that you are identifiable. And therefore, you will be able to go to primary healthcare services centers that are already enlisted. They are on the website again, listed all of them. We should educate our people more which are these facilities. And then you get primary healthcare services universally, whether you have a cover, whether you don't have a cover. You only need to register so that you are identified as a Kenyan and you are verified as well.
What is the allocation from Treasury that goes towards a primary healthcare fund?
So the current allocation is around 13 billion, which you find in the budget. We have not exhausted it. But as you know, government plan continuously. Government budget for what doesn't have, because it relies on collection. But you also get chances after you absorb the resource. There's no need of pushing 20 billion to share. It stays there. It could be doing something else as we wait, so that at supplementary level, if the money is low, then you can bring a supplementary to add some more resources. But we know ideally we'll consume almost 20 billion in primary healthcare.
Okay.
This is the money that will go to the hospital directly. So the FIF law, which people don't know why we brought it, was saying the public facilities have been left behind. So how do we help the public facilities? Because money used to go to the county shareable revenue account. It takes long to come back to them. So there's no services. So the primary healthcare law says that if you provide the PHC services, money will be sent to your hospital that provide services. It is called output-based financing. It's a complete shift from what we used to do before. Because you used to send inputs, like you send a nurse, you send medicine, hope that services would be provided. They are not provided, people suffer. But now you get a service, it will be paid for to the facility you went to. And we expect that as we move, the question of commodity security will start improving. The resources available to these facilities to hire the human resources to be there will improve because the money is going directly to them. Thank you. So that is only one fund. I want to be a little bit quick
What
so
are the
that I
other
finish.
two?
The other two is the emergency, critical, and chronic illness fund.
Yeah.
This is where you discussed a lot with the team that was here. It is the first time we are realizing a national emergency services since independence, where mtu akigongwa na duthi, at least you have somewhere you can just
You can
call,
go, yeah.
and this person is taken care of at least the 24-hour stabilization, and you not go round again in country within an ambulance. No facility want to pick you. They will pick you, they will stabilize you, and the 24-hour stabilization will be paid for by SHA.
By SHA.
It also provides money for very expensive treatment. For instance, cancer. Cancer, SHA pays around 400,000 for chemo. But you see, it goes, for some people, it goes beyond. So the 150,000 come from that critical part of that fund. So that's why we have 550 going to cancer. The discussion now is, given the utilization, because we have the data, who is going beyond 550, how many are they?
Yeah.
So that's why the debate, if you listen to the CEO last time, she said the debate now that is ranging is how do we increase the benefits to cover these chronic cancer cases so that people do not have catastrophic spending.
It's interesting you say that because we have so many questions. That's why we're trying to rush you here a bit so that we can get to the listener and the questions that they're throwing our way. But it's interesting you should talk about that because I'm just wondering, we have just come and we've been pushing for Aga Khan and the fact that they are advising early screening. These are preventative measures, and preventative services. You're talking about emergency services, cancer when you finally have it. What's the coverage when it comes to preventative services? And this includes screening, maternal, mental health, for example, immunization. Are they fully covered, or what's the percentage looking like?
So there are those like immunization that are usually largely covered, right? And I want to say that SHA is not the only financing mechanism. So when
Correct.
the government still allocated resources to go to immunization, look at the budget. To buy vaccines, the money is still there. So SHA is an additive, and it was coming to fill in a gap. The first gap is what you are calling primary care, which is largely preventive.
Yeah.
Address diseases early. They are cheaper. You have 27 million people who have registered for it. If they go to the facilities listed, they will access services and that will be paid for. We want to go further in future as we perfect on the collection to make sure that we increase the benefits surrounding screening so that we identify early. But you must dream but not hallucinate. Now, the dream must be maintained within a trajectory of sustainability. You cannot start SHA today, collect all the money you need.
No.
There is work to be done. There is trust to be bought and provided and earned. And as you do that, you grow the benefits. That is why we began by cancer at 400. We moved to cancer at 550,000. We are moving to cancer at a higher number currently. That is the discussion that SHA is having together with the benefit advisory panel to see how we grow it to that towards that direction. So what I want you to note is that the coverage at the NHIF, and that's a contributory, is crafted within some basic principles. And I want to just highlight one, disease epidemiology. Which diseases do we have in country? 2, catastrophic spending. Which diseases are causing us to do halabase, if I may explain it like that?
Yeah.
3, what are the diseases that bring equality? Now, those key principles, you must consider them. And that is how the benefit of SHA was arrived at. And the question was, to begin with, what was making us to have many harabes? The answer is surgeries, without any need to think. And you look at the benefit of SHA, it is very heavy on addressing the surgery problem. Because that is where big problem was. Number 2 was renal problems. And I love the fact that you have mentioned Aga Khan.
Yeah.
People do not know, as of now, that SHA covers all the cycles of dialysis. If you are a member, and you need a minimum of 2 per week. That is a minimum of 1.1 or 2 million every year. You are a member, SHA is paying. And go to all these dialysis units. They survive on SHA payment. And go to patients of renal who require dialysis. They can't pay. It's too high. That is catastrophic. That is why it is covered. Third is cancers. Cancer, we have cancer treatment will require either chemo, but some require dialysis. Sorry, some require actually surgeries. What you realize that when you have the 400 from social shift, and then you have the 150 from ECCIF, you have 550. Now, this 550, if you require a surgery, it is covered under the surgery component. So the benefits are not as low as actually people have been thinking, because you need to pull the benefit from where it is supposed to be. Caution is that the providers have also not gotten how very well in charging these codes. And I must accept there's work that need to go to educate the provider so that they charge the right places. So that you don't tell somebody you have exhausted your 550 and you have nothing that you are supposed to use. So that is how you look at it. And that is how we have addressed the problem of the 3 major courses. But let me ask you a question this morning. When is the last time did you do harabe for oral? You wanted to remove your teeth. And you heard there was a harabe.
No, that
Or you needed
doesn't
grasses.
happen. Yeah.
Now, people must realize then what are the principles professionally that guide how benefits grow. You begin with what pains more to the society. And the 3 is what pains more.
The most.
But somebody will draw to you that you're not covering oral. Okay? It has never been covered since independence. That's the reality. And the chef never covered. Nobody ever covered within the pool.
Yeah.
But with the growth of the benefit package, you move from where it pains more to where it pains less. But we must grow. This country went to Thailand to benchmark 7 times. Tumekuja kuona what you are doing. They come back from Nairobi to Thailand again. We have come to see what you have done 7 times. The last time the minister came to Kenya, asked us, you have benchmarked 7 times, but you have never started. UHC is a journey. You must start. And starting, we are growing.
Daniel Mwai giving us quite the bunch of information, but I think right now it's only fair. See if we have time, we can come back to some more of our questions. But before that, the most important person is the people that we're serving, whether you're serving them through SHA or you're serving them through Capital FM. The listener is who is important, and we have a caller online, plus a lot of other comments, and we're delving into that one. So how about we delve into it? Good morning.
Yeah, good morning.
Yes, welcome to Capital in the Morning. You have a question for Daniel Mwai.
Yes, I do. It's quite simple.
Your name, sorry.
So is this? Yes, my name is James.
Okay, James, go ahead.
Yes, so my wife works for one of the suppliers who have delivered ultrasound and CT scans to some of these hospitals. Now, it's supposed to be a shared management system, so where they will deliver, manage the systems, and then will be paid via SHA. It has been 2 years. They have not been paid. All I'm seeing is people commissioning and the president commissioning these things and not paying. We keep hearing 2 weeks, 2 weeks, 2 weeks, 2 weeks. Companies are about to be shut down. People are not being paid. People are having to borrow. So I am quite curious to understand, when you say all these dialysis is being done and all these things have been recorded, it means there is a database of the use of this equipment. Why aren't the vendors being paid? Who is eating this money?
Daniel?
Thank you. I think that's a fantastic question. But I want him to also understand that the SHA is not in the business of providing medical equipment to the facilities.
No.
That is not its law.
He wasn't talking about the medical equipment.
No, it's not the medical equipment. They've already been delivered.
So what is not paid?
And they are currently in use. It's supposed to be a shared. The vendors are supposed to maintain the equipment fully, and they're supposed to be paid per service. They have already delivered. There's even records that these things are being used. They have been invoiced. They have not been paid. They have not been paid.
So not for this equipment, for the service?
Yes. So they've already delivered. It is currently being used by the hospitals. They have invoiced. They have not been paid.
Okay, then perhaps he might have a point. You were saying, Daniel?
Yes. So I was saying that SHA is not involved in the placement of equipment. Its law is to pay the hospitals for the invoices the hospitals provide to SHA based on what services they have provided. If you look at the average payment level as of yesterday, so to speak, we are between 69 for some facilities and 70%, around there, 69-70% of the hospital bills that are legitimate and has been verified, because there is also an issue of transparency and ability to verify claims before pay. So the facilities have been paid. All right. Now, the architecture, as earlier envisioned, was you have provided a certain service, you pay the facility, then the facility pays anybody who have placed an equipment under them. All right. Now that has since had a negotiation, and the discussion is how do we assist the people who have already placed these equipments, so that the money should not then hit the hospital account, but the hospital provided the bill that pay this guy because he's the one who placed our equipment in our facility, so that the money does not have to go to the facility, then from the facility to this guy who is our good
James.
caller, James.
Yes, his
So
wife,
for James to actually be sorted is the fact that the arrangement between the county facilities, for instance, and the national government, agreement on how to transmit the resources is the issue, and how to do the split so the money lands to them. Now, I want to also say that this is a very active issue as of now, being solved, because the issue has been raised. He is right. There are placements that have been done. There are money that have already gone to facilities and has not been deducted. The resources that would have gone to the vendor who provided the equipment. But that is an issue that is being addressed. So I would expect that within less than 2-3 weeks, then probably the amicable solution will be gotten on this one.
To be honest, I'll just be frank with you. I've had that 2-3 weeks thing for the last 2 years. So I'm not quite
At least you did not hear it from
in
me.
this government and its ability to deliver. And if you guys are not able to do it, I'm an actuary. I can be able to just come and take that Excel and help you guys out.
No,
'Cause I
it's
don't
not an
understand
Excel
how
issue,
long
it's a
it should
funds flow issue, and the provision of the law in terms of how the funds should be able to move, and it's being
but how
sorted.
is
We have
it
to
so
be
easy to
right
collect the
in our
money?
law. We have to follow the
then
right
dispersal
procedure
becomes
to
an
actually
issue.
push the resources.
He's just wondering why it's so easy to collect the money,
Collection
but then
is very
the
easy.
payment
Yes.
is. James, I completely understand your anger, and when you said you've heard the 2 weeks thing, kind of, I'm gonna get in trouble for this one. Kind of reminded me in 2 months' time, the stadium at Wote and other African stories, which is
Thank you.
a big concern, whether we like
Exactly.
it or not. But to be fair, Daniel has said that it's being worked on. I just do not think it's fair to give a time limit to a person who's been dealing with time limit issues. James, sorry, I know there's so much more you want to say, but in the interest of time and in the interest of hearing other people's opinions, I'll have to say thank you for the call. And you have this number. If it doesn't work out in 2 to 3 weeks' time, give us a call. You know how Fellaris and I do. We say it out loud and we say it proud. We'll be the first ones to call Daniel Mwai and follow up, because we've never heard it from him. Thank you. That's James. Thank you very much. I wish him, his wife specifically, and the people in that company all the best. Here's another listener, James.
Good morning, Chiko and Fellaris. Okay, I'm listening to Daniel Mwai in the studio, the presidential advisor on health, financing and all. He's really doing a good job of letting us know that SHA is working and SHA is better and all that. I have 2 questions that are related. Question 1 is, how much was NHIF, by the time it was being scrapped, how much was it owing medical facilities in Kenya, all the medical facilities? How much was outstanding that NHIF had not paid? That's question 1. And question 2, how much was the SHA system? People claim, it's claimed that it used about 100 billion to create the system. And if it's true it created 100 billion, what sort of economics is that?
So this one you have to answer quickly, because it's follows up on our streaming platform, in which Brian Abaja also asked, I understand re-engineering NHIF to SHA, especially output-based model, but why spend 104 billion on new IT system?
Thank you very much. I think I'll start with that one. I was waiting for it, and it always come every time. But I think it's also good for Kenyans to have the right information. And I love the fact that Capital has given us a platform to actually air some of these things. And I will not go too much on it, because you know it's subject in court.
Yes.
But I want to highlight the principle rather than the 104. And I want to say this, that SHA system is not 104 billion. That's a fact. All right, but the DHA systems, they are 38 in number, is 104 billion. Okay, that will be paid in 10 years. That means maybe 10 billion a year. Okay, and in that 10 billion is the 38 systems that we have there. Now, let me say these systems are what? The SHA systems are largely 2. The first system there, because the new change again from the NHIF we want. Earlier, SHA was providing its own, NHIF was providing its own system that was inside, which was prone to manipulation. Now, the separation of functions within the SHA framework is that Digital Health Agency is a provider of all health systems, and SHA is a user. So you need a lot of collusion there to actually manipulate the system, because each have its own law, it have its procedure, and therefore the provider cannot get inside to change things. It has to communicate, and people don't like communicating also if they are doing a long thing. So that's a complete separation. But this system is trying to fill several things, and I want to highlight one is SHA has the system that processes claims, is the one that is AI driven, is the one that receives claims from facilities. Two, it has an ERP, that is what manages the workings of SHA inside itself. Now, all the other systems are systems it uses, but it doesn't, they don't belong to them. A good example. Now, for SHA to pay, you need to know whether a doctor is legitimate or fake, like a Mwai Rimo. So there is a system that links with the medical board, nursing board, and all the others. So when you log in, it hits those three, depending on your cadre. If you are legitimate, you log in. If you are not, you cannot log in. So a Kenyan will not have a Mwai Rimo treat them and charge SHA. Or any other, because this is beyond SHA. It's for public, private, and faith-based facilities. Two, you have the one for medicine. One of the key problems we have with the PBB, again, so that's a PBB system, is that we are unable to track the fake medicines in our circulation. Now, a study that was done recently was showing that the medicine, the injection you give mothers to stop bleeding after they give birth, almost 60% is actually fake. But that's a great why our mothers are dying in hospital. Because if you have fake medicine that finds its way in either public, private, or faith-based hospitals, a mother is bleeding, you inject the mother, the bleeding does not stop. But how do you know whether it's legitimate or not? You need a system that will read the drugs and poison boards. You see whether this medicine is actually supposed to be prescribed. That's another system. We have a track and trace system that should follow the medicine from whoever made it to whoever consumed it, and must be identified as Daniel through their biometric, through their OTP, and they are uniquely known. That's another system for identification and verification and biometric. I can go up to 38. All right. By the time I go to 38, I will say this. This money also include storage, cloud storage for all facilities, for data for health for 10 years. It has airtime for public facilities, airtime, because if you don't have airtime, the system does not work. So it have airtime for public facilities for 10 years. It has devices, this is tablets and other gadgets that are needed at facility level to provide the service for 10 years. Now, when you break it down, the 10 years, you will be surprised. Needless to tell you, just a small thing. The system that NHIF was using, we were consuming more than 490 million in a year. By the time we came, it was almost 700. That would have costed 7 billion in 10 years for SHA only. Okay? But now, the system that we have, that is for SHA, in specific, inside the 104, will barely cost 2.3 to 4 billion in 10 years. So the economics is so right. And I must say that I'm one of the people, if you look at my past records in this, is how do we have sustainable financing for the African context and have our data kept safe? And that's what we are solving.
Dr. Daniel Mwai, President's Advisor on Health Financing. I'm actually going to ask you to spare 5 more minutes in the next hour, because a few questions have come and I'd really like you to respond to them, one of which being all good on proportional contribution, but the benefits should somehow also tally. I pay more, I get more, all in keeping with the spirit of proportionality. But then he wants you to comment on the ongoing NEMIS project for equipping hospitals. There are facilities where functional equipment is being removed moved by forced orders from above, in quotes. Secondly, that revenue sharing model is not practical and facilities won't be able to shoulder their running costs. Example, a CT scan costing 6K, the facility is left with about 600 to pay staff, electricity, infrastructure, other incidental costs, while the private investor maintains the machine and provides consumables only. The math is not okay, ground. That's something we'd love to get an answer on from Dr. Daniel Mwai. And also this.
Can you please ask him why the vendors for FFS, the management system of equipment, they're not paying the vendors? They've not paid the vendors for the last 2 years.
Those questions be answered in the next hour.